Okay, so good afternoon, everyone, and welcome to Transfusionist Talks, Transfusion Made Bloody Easy. My name is Donna Berta. I'm a nurse with ORBCON, the Ontario Regional Blood Coordinating Network. Our work is inspiring and facilitating best transfusion practice in Ontario. I'm going to turn my camera off so I have more bandwidth. And so this presentation is being recorded, and as of July 6th, the slides and recording will be available on our ORBCON website. The link is there. You can select the resources tab, search for presentation library, and then scroll to Transfusionist Talks to find it. Again, by participating, you indicate your consent to the recording, archiving, and use for educational purposes. I will start off with land acknowledgement. We begin by acknowledging that this virtual event is hosted from the traditional territories of the Mississauga and Haudenosaunee Nations within the lands protected by the Dish One Spoon Wampum Agreement. Please acknowledge and reflect on the land where you are joining. You will be able to, at any point during the presentation, submit questions through the Teams Q&A function. Following the presentation, I will be available, and it's optional if you want to attend the additional 15 minutes to discuss questions. If there are more questions than time permits, we will post the answers with the recording. There are going to be some polling questions. Some hospital firewalls, unfortunately, block this technology, so some of you may not be able to participate in the polls. But please answer the questions personally and consider your answers as compared to the group. So our topic today is platelet transfusion, a sticky process. I don't have any commercial product conflicts of interest. I am a member of several transfusion-related committees. So we'll begin with some questions. These are some knowledge questions. I'm going to have you answer them now, and then we'll answer them again at the end and have a discussion about the correct answer at that point in time. So for this question, for adult patients, the transfusion of platelets is indicated A, for bleeding patients taking antiplatelet medications like aspirin and Plavix, regardless of their platelet count, only for patients actively bleeding, only for patients if the platelet count is less than 100, or prior to neurosurgery if the patient's platelet count is less than 200. And I'll give you an opportunity to respond now.
And it looks we have, oh, there's some more coming in. So we have 31% said A, 15% were D, 30% B, and 24% were C.
Okay, so a little bit all over. And again, as I mentioned, we'll address the correct answer at the end of the presentation, and hopefully you'll hear it throughout the presentation as well. And our second knowledge question, when administering platelets, it is important to infuse normal saline at 25 mils per hour at the same time, monitor the patient's temperature every 20 minutes, use a new blood tubing filter set, or finish the transfusion within 30 minutes. And again, I'll give you a chance to respond now.
Okay, we have 97% that say use new tubing filter set, 6% are monitor temperature, and 5% are complete transfusion within 30 minutes.
Okay, very interesting. Again, we'll come back to those questions and discuss the answers. So objectives today, we're going to talk about the role of platelets, about Canadian Blood Services and their production or manufacturing steps, about indications, and then we're going to talk about some nursing actions to safely administer blood that is specific to platelets. So what do platelets do? Without taking too deep a dive into physiology, platelets are basically the first responders for clotting. They bind to the site of blood vessel injury when a blood vessel is injured, and then they will bind to each other and form the platelet plug, which in turn then leads to activation of the clotting factors and bleeding will stop. The platelet life cycle is about 10 days, so it's relatively short, and a normal platelet count is anywhere between 150 to 400 times 10 to the 9th per liter. So in terms of how Canadian Blood Services makes platelets for us, this is a process of whole blood collection. So you can see here that the blood is collected from the donor and an anticoagulant is added. It's cooled, it's centrifuged or spun, and then that separates into the layers. The plasma is on top, on the bottom are the red cells, and in the middle are the white blood cells and the platelet. And that middle layer is called the buffy coat layer. And you can see from this diagram here that there are still a few red cells in there, and there are some white cells as well. So even though it was spun, there is those additional factors in there. And then that is further processed into pooled platelets. And how that happens to produce pooled platelets, Canadian Blood Services takes 4 of those buffy coats and the plasma from 1. It's all combined, and then it's centrifuged, and then that leads to more of the red cells being extracted and filtering to take out the white blood cells, and then you have platelets suspended in plasma. And so when you're giving a platelet transfusion, you're giving platelets, but you're also giving plasma at the same time. And this picture here is probably a little bit misleading in that it shows no white cells or no red cells in this bag. And actually, there are a few residual white cells and a few residual red cells. The other part of platelet manufacturing is routine bacterial screening. So platelets have to be tested for bacterial screening. That's because they are stored at room temperature and there is increased risk of bacterial sepsis occurring in a patient who receives a platelet transfusion. So that's pooled platelet production. Canadian Blood Services also produces apheresis platelets, and it's essentially the same thing, except for this time it's one donor who is whose platelets are extracted through an apheresis machine. So there you end up with platelets just in that donor's plasma. And again, routine bacterial screening is required for those apheresis platelets as well. And these are the platelet products that we've historically been used to transfusing in Canada. Canadian Blood Services is always striving to make blood as safe as it possibly can be for our patients. And so in 2022, they introduced pathogen-reduced platelets. And this technology, while being new to Canada, globally is not new at all. Pathogen-reduced platelets have been used in Europe since 2002 and in the United States since 2014. So they are indeed very safe. And the good part about this new change for us is that these pathogen-reduced platelets are used for the same indications and they're transfused following the same procedures. So what's so different about them? Canadian Blood Services, instead of suspending them solely in plasma, the platelets are a platelet additive solution called PAS-E is used, and some plasma in about a 60 to 40% ratio. So there's less plasma. And then there is this intercept or pathogen inactivation technology. And there, viruses, bacteria, protozoan parasites, and white blood cells are inactivated by this technology. What are the benefits? Again, decreased risk of bacterial sepsis. We don't have a quantification for how decreased that risk is, but theoretically it should be 0. There's lower risk of other transfusion-transmitted infections. There's potential for fewer allergic reactions because we have less plasma. Irradiation is no longer necessary for these pathogen-reduced products because the white cells are inactivated. And we no longer need to do bacterial testing. So the platelets are issued to hospitals earlier in their shelf life. The downside of this is that when these pathogen-reduced platelets have been approved by Health Canada. In studying that, the platelet count is mildly decreased post-transfusion compared to the previous platelet products. Although when they have been investigating this, they have found that there is no difference in the bleeding outcome in the patients, even though the platelet count is not as increased as it would have been with the previous platelets. Pathogen-reduced platelets are not for all patients. If somebody has a hypersensitivity history to amotosalen or other Sorolin products, or we also have no information on using pathogen-reduced platelets in intrauterine transfusions, so alternatives are needed there. So essentially, these pathogen-reduced platelets, and they're called pooled platelets Sorolin treated. So PPPT is the acronym. It's the buffy coat from 7 donors, this platelet additive solution to make the 60-40 ratio with plasma, centrifuged and filtered, and then we have this bag of platelets in plasma. The pathogen inactivation technology includes adding amotosalen, exposing it to ultraviolet light, and then the amotosalen is also removed, and then that product is further divided into 2 doses. So that's our pooled platelets that are Sorolin treated. There are also apheresis platelets that are Sorolin treated, which essentially is the same process in terms of the pathogen, in terms of the additive solution and the pathogen inactivation technology, just that they're apheresis platelets, so from 1 donor. And then on request, Canadian Blood Services will also be manufacturing apheresis platelets in PAS-E solution. So this is going to be for those patients who have a hypersensitivity risk, or for where the indication is intrauterine transfusion. And for these platelets, routine bacterial screening will need to be done for those particular platelets. So these next slides are a summary of what these bags of platelets of the various type looks like, because there are 5 of them now, and you can see that they are a little bit different. And I also have put together a chart comparing various features of these 5 platelet products, because for a time, up till sometime in 2024, until all the Canadian Blood Services production sites have adopted this new technology, we're going to have 5 potential types of platelets around that we'll see for transfusing to patients. So I'll provide that to you for your reference in terms of what the differences actually are and how they compare. But again, they can be used for the same indications, and they are also transfused in the same way, just that these new platelets are going to be safer for our patients. So we'll move on next to a patient case. This patient's name is patient A, Epic 2, surname JHPF, and that's because they're from a test patient from a computerized system, so they have a funky name. The patient is a 33-year-old female. She was previously well, except for some chronic back pain that she took some aspirin for, and now she's been admitted and diagnosed with leukemia. She's undergoing chemotherapy treatment. Her hemoglobin is currently 84. Her platelet count is 8. So in this patient case, the appropriate indication for transfusion and would be A, the patient's diagnosis of leukemia, B, the patient is feeling weak and fatigued, C, for the past month, the patient has been taking aspirin on a daily basis, or D, this would be a prophylactic preventative transfusion because the platelet count is less than 10. So I'll give you opportunity to select a response now.
Okay, we have 97% saying it is answer D, and 2% B, and 2% for C.
Okay, and indeed, the correct response is D. This is a preventative transfusion because the patient's platelet count is so low. The indications for transfusion for adults are summarized in this chart, and you can see that it is a little bit complex, and it is based on various clinical scenarios listed here, and then various platelet counts aligned with those clinical scenarios. So our patient fits in here. The less than 10 in prophylactic transfusion. I will make comment as well, platelet function is a factor, and in that scenario, platelet number is not a factor because medications like aspirin or Plavix will affect platelet function in terms of their ability to be sticky and cause the clot to form, as well as cardiopulmonary bypass. So patients who are in those scenarios and having significant bleeding, it doesn't matter what the platelet count is, platelet transfusion should be considered. So in adults, the dose is 1 unit of platelets. Platelets, as I mentioned, are stored for 7 days on an agitator. They are stored at room temperature. If platelets were chilled, they would, or refrigerated, they would be hemostatically active. However, the hepatic macrophages would quickly clear them out of the system, so they wouldn't be around for very long. General historical guideline is to transfuse over 60 minutes. We're going to talk about TACO down the way a little bit. And usually 1 dose will increase your platelet count somewhere between 15 to 25. And that's usually sufficient for hemostasis to happen. The dose for neonates and pediatric patients is a little bit different for these Sorlin-treated patients, 8 mils per kilo versus 10 mils per kilo for other platelets up to a maximum of 1 unit. And this is for your reference, again, the guidelines for neonatal and pediatric patients as per Bloody Easy 5. So now we'll look at a physician's order for platelets for our patients, since we've come to the conclusion that yes, a unit of platelets is needed for this patient. So this computer order has the patient's name, which we need. It has the patient's hospital number or their unique identification number called MRN in this facility. We've got a date and time, and then it's telling us, this order is telling us to transfuse 1 unit of platelets. So as it appears, this order is not really complete. We need some more information to be included in this order. And what should that additional information be? Do we need the patient's diagnosis? Do we need the rate or duration of infusion? Do we need the patient's platelet count? Do we need an order for a prophylactic antipyretic medication? So I'll give you time to select your answer now.
Okay, it looks like 75% are saying B, and the next closest would be 12% with A, and a few people are C and D.
Okay. And indeed, B is the correct answer. We do need the rate or duration of the infusion to be included in the order. Some facilities may have a standard operating procedure that says a standard rate, but in barring that, you do need it to be in the order. The patient's diagnosis and the patient's platelet count are factors in coming to the transfusion decision or not, but they are not mandatory to be listed out specifically in the order. And prophylactic antipyretic medication would only be indicated if the patient had had multiple febrile reactions. This is the list of all the order requirements standard for any blood transfusion for your reference that I've provided there. And so before you can go ahead and transfuse these platelets, we need to have a few things. And the first thing would be we need group and screen test results. So in this computerized patient chart, we've got a group and screen result of O negative and negative antibody screen here. We also need to have informed consent, and this computerized documentation prompts us to check for that. If we didn't have an informed consent form according to the hospital policy, then we would not be able to transfuse. We should not transfuse, and that needs to be obtained. This would be the point in time when we want to think about TACO risk, and we are going to talk about TACO risk next. But we would want to think about that. If we need to take some actions, then we need to deal with it sooner versus later. You do need to have a dedicated IV. Make sure it's patent before you ask for the platelets to come from blood bank. And a routine platelet transfusion, the gauge would be 20 to 22, neonates, pediatrics, anywhere from 22 to 25. It also is important to give, where it's appropriate for the patient, to give the patient some information. So we want to let the patient know what to expect. We want to let them know what signs and symptoms they should be calling us for right away. And so OrbCon does have in the link here, we do have electronic as well as a printable version of patient education information. And also there is a video that's less than 4 minutes that patients can watch that will explain the basics information for transfusion to them as well, if that's of interest to your patient population. And then getting closer to the time when we're going to start the transfusion, we do need vital signs and a patient assessment to have as a baseline. So TACO, we really do need to talk about TACO because it is the leading cause of transfusion-related deaths. It happens because the transfusion was going very rapidly and the specific patient, their cardiac capacity, could not tolerate the volume that's coming in. Signs and symptoms are respiratory related as well. With TACO, because of the fluid overload, you'll see increased blood pressure versus other transfusion reactions. You're more likely to see hypotension as a feature. TACO risk factors, the elderly, people with heart failure or heart dysfunction, people with kidney problems, people with a positive fluid balance. If you see risk, then indeed you should be talking to the prescriber to look at prevention strategies. And those can include only giving 1 unit at a time. So if you're needing to transfuse red cells and platelets, which do you need first? Can you wait to transfuse the other, but not both consecutively? Transfuse over a longer time period. Historically, platelet transfusion has been over 60 minutes, but I think that's one of those historical things that we do because we can give platelets over a maximum of 4 hours from the time they were released from the blood bank. Pre-transfusion diuretics can be key. That's important to make room in the patient's cardiac reserve to receive that additional fluid by getting rid of some fluid ahead of time. And also, some blood banks are able to divide units, so they could take the unit and separate it into 2 separate bags and then issue them separately so that each half unit could be transfused over a maximum of 4 hours. So those are some strategies that can be considered and should be implemented whenever there is the slightest evidence of risk. So transfusing platelets, you do definitely need blood tubing with that 170 to 260 micron filter. Always, we want to have new tubing for platelets to be transfused, and that's because when the purpose of the filter is to capture any fibrin in any of the blood components, red cells, plasma, platelets, they all have a bit of fibrin. And so if the filter was used and there's some fibrin already in there, the platelets are going to adhere to that fibrin and they're not going to get to your patient. So always a new filter, only compatible with saline. No medications are compatible. You can prime the tubing with saline or with the platelets, and you do want to set up your IV so that you can stop it abruptly and still keep the IV access maintained. So you can do that if the patient has a pre-existing IV line, you can use saline flush syringes and then that line, or if there's no pre-existing IV line, set up a new one. Devices are encouraged, but they must be Health Canada approved, and that could be the Alaris pump or the Baxter pump. This picture shows the Alaris pump. Generally, not recommended blood warmers or rapid infusers for platelets. Platelets are already at room temperature, and a rapid infuser, if you're needing a rapid infuser, you're probably infusing a lot of blood products, and if you've already put other blood through that rapid infuser filter, then if you put platelets through there, the platelets are going to stick to the filter, maybe even clog the filter, maybe even necessitate having to change the filter and the tubing right in the middle of your needed rapid infusion. So for platelets, it is recommended that you just use, even in a rapid infusion scenario, that you use regular blood tubing, new tubing, and then you use your pump set at a maximum rate to transfuse the platelets in those bleeding patient scenarios. We're going to talk a little bit about checking blood. Patient identification is paramount. There are 4 steps to checking blood. We're going to focus on the ABO and RH blood group checking step. This is the patient identification that's checks here for your reference, but ABO and RH blood groups. So we want to check they should be identical or compatible, and I've added a proviso as feasible for platelets. So what do we need to check? We need to check the group and screen, and here we see our, that's the one source of truth, the group and screen test results for our patient's ABO and RH group, and we can see that she is O negative. If we look at the Canadian Blood Services label, we can see the ABO and RH group for the unit that we're going to transfuse, and here we see that it is A positive. And then in this particular blood bank, they put the transfusion label on the same side of the bag as the CBS label. Some blood banks will put it on the other side, but here they've got it on the same side. Nonetheless, we can see if we strain our eyes that the patient's blood group is O negative on this transfusion label, and the platelet is A positive. And again, on the chart label that's going to go on the patient's chart to document the transfusion, the patient is O negative and the unit is A positive. So something seems a bit off here to me. The patient's O negative and the unit that they've sent us to transfuse is A positive. What are we going to do? And here you can select more than one answer if you feel it's applicable. So A, should we transfuse the platelets? This is what blood bank has issued for this patient. Should we look at the compatibility table to see if there are any insights there? Should we just check the patient more frequently, like every 15 minutes during this transfusion? Should we give a call to blood bank? So I'll let you select one or more answers there.
It looks like we have about 44% are call TML, 47 are check compatibility table, and we have a few that are going to transfuse the platelets and a few that are going to monitor the patient.
Okay, so I would be most comfortable with not transfusing this patient right away. This doesn't seem quite right. I want to at least look at the compatibility table, see if I can convince myself that this is right, and then maybe I'm still going to call blood bank. Just monitoring the patient more frequently, if this is incompatible, that isn't going to be of very much help to the patient. So let's look at this compatibility table. Here's the compatibility table, and you can use it for any blood component that's listed. So the patient's group here is O negative, okay, and we're transfusing platelets. So it's telling us that O is preferred and RH negative. There's some provisos over here, and we'll take a look at those on the next slide. But while we're looking at the compatibility table, if we remember, platelets are suspended in plasma, so it's like giving plasma as well. So this compatibility table is telling us for plasma, you could give this O negative patient OA, B, or AB. So this A platelet might not be so bad for this patient. So what are the provisos there? So platelets do have A and B antigens on their surface. They don't express RH antigens. As we talked about, they are suspended in plasma, so plasma is pertinent in this case. And there is a small amount of red blood cells in that bag of platelets, and red blood cells do express RH antigens, so it is important to consider RH. Ideally, for any transfusion, we always want to transfuse ABO and RH blood group identical patients, but often that's not possible because platelets have a shelf life of only 7 days and only 15% of the population is RH negative, so there just aren't enough RH negative platelets to go around. If the transfusion isn't urgent, Canadian Blood Services is going to check with, the lab is going to check with Canadian Blood Services to see if they have any group identical platelets available. But then when you get into that scenario, you have to think about delivery time as well and how long is it going to take to get to the hospital. If a patient is RH negative and RH negative platelets are not available, we will give them RH positive platelets. The risk of making the anti-D antibody from platelets is low, only about 1%. But for patients who are excuse me, female, Rh negative female, and with childbearing potential, if they are transfused Rh positive platelets, there is potential that they could make the anti-D antibody, and then if they go on to have future pregnancies, to develop hemolytic disease of the fetus and newborn in their baby. So to prevent that, we would give them Rh immune globulin if they were transfused an Rh positive platelet. For females not of childbearing potential or males, if they were Rh negative and transfused an Rh positive patient, we would not give them Rh immune globulin because Rh immune globulin, it will stimulate them to produce a passive anti-D, and then that can have impacts for on doing cross-match testing while that passive anti-D is in the patient. So it's reserved strictly for the high-risk females of childbearing potential. If ABO group identical platelets are not available, the blood bank will issue ABO plasma compatible platelets, and that's what happened here in this case. The A are plasma, the group A platelets for this group O negative patient are plasma compatible. If there were no plasma compatible platelets available, then we do sometimes have to transfuse plasma incompatible platelets. In those scenarios, the prescriber will get notified by the lab, and there's more information about that in the platelet transfusion toolkit. So checking ABO and Rh can be a bit of a rabbit hole, and certainly always, if you're not clear, not comfortable, call blood bank and they are sure to help you out. This is checking unit number. This is the visual inspection and expiry. That's the same as for any transfusion. So the infusion rate for platelets, as long as it's not urgent, the patient isn't bleeding, then we should start the transfusion slowly. And so for the first 15 minutes, adults, we're going to do 50 mils an hour, and for neonates or pediatric, it's 1 mil per kilo, up to 50 mils an hour maximum. And when you're doing that, you do have to remember, if you primed your tubing and filter with saline, then you do have to reprime with the platelets to make sure this initial slow infusion is really giving platelets to the patient, because the volume of the tubing, the Alaris is 33 mLs, Baxter is about 15, so you do need to do that repriming step for your patient's safety. After 15 minutes, if everything is okay, there's no signs and symptoms of a reaction, then you can go to the rate that was ordered. Assessments and vital signs. Baseline, we want to think about, has the patient had fevers? Have they had rashes? Are they on oxygen? How is their breathing at baseline? We may want to listen to their chest if they're at TACO risk. If somebody has a fever or a rash, it doesn't preclude transfusion. You just have to be aware of it and have a good assessment of what the baseline was. We do want to have a full, complete set of vital signs, including oxygen saturation, because if there are any signs and symptoms of a reaction, we want to know where the patient started off. And how often should we do this? The minimum requirements are 30 minutes before we start, 15 minutes after, when the transfusion is completed, and if a reaction is suspected. Some hospitals may require more frequent monitoring. It just depends on your hospital policy, but that's the minimum. So we'll go back to our patient. So the platelet transfusion is finished. You're disconnecting the tubing and you see these hives, and the patient tells you that they're itchy. When you look at the rest of the patient's body, there are no other hives, and the vital signs, they're pretty much unchanged, pretty stable, not much difference. So what should you do here? And again, you can select all that apply. Should you call the physician? Should you verify the patient identifiers on the armband and the transfusion label on the platelet bag that they are identical match? The patient has a PRN order for Benadryl. Should you be giving them Benadryl? Should you be calling blood bank? So again, I'll give you some time to respond.
So we have 42% call the patient's physician, the 33% are going to administer Benadryl, and a few others are going to verify the patient identifiers and call TML.
Just a few are going to call TML?
Yes.
Yeah, okay. So for sure you can do all of these things. You want to notify the physician there's been a change in the patient's status compared to previous. You do want to check the patient identifiers. Is this the right platelet for this particular patient? Is this what is this correct? Because you see this rash now, maybe this rash is going to evolve into something more. So you do want to check the identifiers whenever a reaction is suspected. If you do have Benadryl order, you may want to start to give that before you hear back from the physician, just to prevent anything further from happening, hopefully. And you always, for any reaction, no matter how minor, you want to let blood bank know about it. It's they need that information. And so this is just a list of the steps to manage a transfusion reaction. If the transfusion had still been running, you, of course, first step is to stop the transfusion and switch over your IV. You do need to, as I mentioned, report all reactions to Canadian Blood Services, because they sometimes have to report certain types of reactions further along because it may have implications for other blood products. This is an example of computer documentation, and again, that can be helpful in prompts for documentation of reactions. So those computer systems do have some merits, even though a steep learning curve. This is the acute reaction chart that Ontario uses. On the right-hand side, these are the recommended indications and the suggested treatments, and it does cover a range of types of reactions: fevers, rashes, dyspnea, and hypotension. There is a page 2 for that, but these two right-hand columns are what you want to look at. Categorizing and classifying the reaction is the responsibility of the transfusion medicine physician, and they will be more acutely looking at those things. This is the platelet checklist, a transfusion checklist, a 1-page of guidelines, and that do also apply to platelet transfusion. And so we'll go back to our initial 2 questions. So for adult patients, transfusion of platelets is indicated, and I'll let you review the responses and select your answer.
So the majority are answering A at 74%, 22% are C, and a few at 3% are D.
Okay, and great. The correct answer is A. That's the only statement that is completely correct in and of itself. Just if the patient is bleeding, that's not an exclusive indication, and the patient's platelet count is also not an exclusive indication. Usually those things are taken together in combination in some fashion. And for neurosurgery patients, it's if the patient's platelet count is less than 100. And our second question: when administering platelet transfusion, it is important to, and I will let you review the answers there and make a selection.
We have 100% that are answering C.
Excellent. Yeah, there's no need to infuse saline concurrently. Monitoring the patient's temperature more frequently is not going to be of benefit, and complete the transfusion. It's within 4 hours from time of issue, not 30 minutes. So that's great. I do have some acknowledgements, my transfusion medicine family and friends, some specific people at McMaster who helped with this presentation, the Boris Clinic nurses, Noor and Felicia, Dr. Arnold and Dr. Zeller, and as well Canadian Blood Services, John and Amanda were very helpful with this presentation as well. I also will acknowledge the Ministry of Health because they provide funding for ORBCon and allow us to do what we do. I have some references. And I will entertain any questions that you've put in the chat. Before coming to that, though, I do want to thank the folks who have helped organize this, and thanks to you for participating. I'll let you know that there will be another Transfusionist talk coming up in September. If you have a case that you would like to see presented or a particular topic, you can email me or you can include that in your evaluation survey. This is the evaluation survey. There's a QR code there for you to use. The link is also posted in the Q&A, and the link will be emailed to you in a day or so. We will have that. Once you complete the evaluation survey, you will get your certificate of attendance, and you will get a written version of the knowledge questions with some rationale. And at this point, we do have this additional 15 minutes to discuss any questions that may be in the Q&A.
There are no questions.
No questions?
Sandra's asking if the information is available for us to share. If you do have a question, as I see some people raising their hands, you need to put it in the chat or in the Q&A, and then I can read it.
Okay, yes, the slides and the recording both will be posted on the Transfusion Ontario website, and it will take about a week. They should be posted by July 6th at the latest.
Just gonna check to see if anybody, because I saw a hand go up, but don't see any messages coming through in the chat. Oh, there we go. I missed this. I missed the beginning, and this may have been answered, but we need to run platelets and PRBCs. We currently use new blood tubing for each product. Could you run platelets through RBC with the same tubing?
No, I would not recommend that. The tubing, generally speaking, is good for 4 hours of time. Some hospitals say have a policy of only 2 units. Some hospitals say 4 units. 4 units or 2 units, whichever, and then 4 hours, whichever comes first. So depending on how quickly you're running them, you could transfuse the red cell and then you could transfuse the platelet and then the red cell after the platelet with the same tubing, but not vice versa. We would not want you to transfuse the red cell first, because then there's going to be some fibrin in the filter, and then if you transfuse the platelets after, they're going to get stuck to that fibrin, and your patient won't get the most benefit. So if it's within 4 hours, you could do the platelet first and then the red cell, but not vice versa.
And that is, oh, what additional monitoring is required for ABO incompatible platelets?
If you're transfusing ABO incompatible platelets, we're looking to see if hemolysis is going to, if the patient's going to have a hemolytic reaction. So you would be the physician would be advised to monitor their CBC for a few days period of time, and you would want to watch the patient for any symptoms of hemolysis. So if they had tea-colored urine, dark urine indicating hemolysis, or if it became very acute, if they developed acute distress with hypotension and tachycardia and fevers and the whole gamut, just like an incompatible transfusion, that could potentially happen. Does not usually, because again, there's only a few red cells within the platelet.
Okay, do you know of any difference in risk for TACO between PP-PT and the original CBS platelets?
I will just go back. I'm guessing that I've got the right slide. No, I don't. On this slide, the only additional risk for TACO would be the volume, because our pooled platelets that we've had and our apheresis platelets that we've had over the years, these are the mean volumes of the unit. So for pooled platelets, it's 317 mLs. The Sorlin treated platelet unit, the mean volume is 184 mLs. So certainly they are less volume, and so may be better tolerated from a TACO perspective that way, but that would be the only difference that I'm aware of.
I do not see any more questions popping up.
Okay, well, if someone does have additional questions, you can always email me. And with that, I thank you for your attention. Whoop.
I apologize, Donna. There is
No.
one more. Sorry.
Sure.
Volume
No problem.
reduction is not recommended for PAS-E or Sorlin treated product. What is available for that need?
Yeah, it is not recommended. That is a CBS product monograph recommendation, so I would not go against that. I would not do that. In terms of if you needed, if volume was an issue and you needed to do that, you need to do something. I would think that only dividing the unit would be your only feasible option. I will consult with Canadian Blood Services to see if they have any particular advice for that, but I do recall from the product monograph it does state that, and I don't believe it gives you any advice. So I can follow up with Canadian Blood Services and then include that information with the recording.
Now that's it.
That's everything?
Yeah,
okay.
Thanks, Donna.
Okay, well, thank you very much for your attention. I hope this was helpful, and we will have the recording and the slides for you next week. Thanks so much and enjoy the rest of your day.